I'm Lucy Chappell. I'm a professor of obstetrics at King's College London and a consultant obstetrician at Guy's and St Thomas's Hospital. And I've starting in the role as Chief Scientific Advisor to the Department of Health and Social Care and co-lead for the National Institute for Health Research. I've had an interesting career path with plenty of zigzags along the way. Some of which is sort of fairly predictable, and some of it which is marked by unusual opportunities. So I went to medical school starting at Guy's and St Thomas's, and then slightly unusually did my clinical medicine in Cambridge, so sort of the opposite direction to the one that most people took at that time. And then I thought about a number of options, including trauma surgery, following an elective in the States, but settled on obs and gynae as an amazing specialty that involves looking after women, particularly in pregnancy, at an extraordinary moment of their lives. And having started clinical training, I then, it was at a time when the training numbers were all being reorganized, and so I had the opportunity to go sideways into a PhD, which I loved. And came back and sort of carried on with training, including subspecialty training in maternal fetal medicine. And then, again, by a slightly coincidental route, took up a lecturer job and went on to be a new blood Department of Health NHS clinical senior lecturer. I was then put forward for an NIHR research professorship, which was transformative, brilliant. And I've just finished that and become an NIHR senior investigator. And then the opportunity to apply for this job came up, which I took. So when you ask what's a typical week, one of the excitements for me is that I don't really have a typical week. As some activities are fixed. At the moment, I do a clinical day on a Wednesday, and so that gives me a bit of structure and a bit of direct contact with the clinical service through looking after high-risk pregnant women. And the rest of the days are busy with a whole variety of research activities, some of which are my research projects. I work in the area of pregnancy hypertension particularly, and some of the other maternal medicine complications. So it may be meetings with my project team. I work with a variety of clinical trials units around the country, and I do a lot of multi-center trials. And I really enjoy talking or working with investigators and clinicians across the country. And I also do some institutional and some external committee work. For example, I'm the chair of the NIHR HTA Clinical Evaluation and Trials Committee. And so that will involve getting ready for a funding committee, chairing a funding committee, and then all the follow-up work. But probably one of the excitements for me is the variety. And that involves maybe one-to-one meetings with my group, teasing out a challenge, through to sort of much bigger meetings. So for me, that variety is a really key feature of the career, and it's a mixture of the science and the relational aspects of the work that keep me very stimulated. I'm passionate about medicine and about research and science, and it's that variety that gives me that passion, with this aim of improving outcomes, in my case for pregnant women, in my research. But that's something I get up for every morning. So the greatest challenges at the moment are to ensure that we conduct ethical research in the appropriate regulatory frameworks. But I think something that a lot of researchers recognize is the red tape. And what we are trying to do is to steer a path through the necessary frameworks, but not so overwhelmed by that red tape. So I've been the national pregnancy lead for the recovery trial in the last year through the COVID-19 pandemic. And I think that trial has been a brilliant example of where the UK stepped up to deliver findings that have been translated into clinical practice, not just in the UK, but globally. And that trial was, the global leader in terms of numbers, but also in terms of delivering results. How did it achieve it? Because it did have that framework, but it also encouraged collaboration between researchers and the clinical workforce in a way that I don't think we've seen before. And that's something that I would be really excited to see continue. So as we've talked about with the vaccines, it isn't at the cost of the appropriate oversight. It is just that the oversight has been speeded up where appropriate, but is still done to the same depth. And I think that from the research perspective, this is going to be an ongoing challenge that we will need to address after the COVID-19 pandemic, but we've got a really good blueprint for what it could look like. Clinically, my challenges are related to the inequalities that exist in health, and that is something close to my heart. I work in St Thomas's, which has got Lambeth and Southwark, and both from a ethnicity perspective and a socio-demographic perspective, the health inequalities are there. And so the challenge going forward is how our country addresses those health inequalities, and more widely, the social care challenges that come with that. And in other areas, I could talk about mental health, and how we as a community, both from the clinical perspective, from the research perspective, really step up to address that. So many people have been working in this area for a long time. We have to look at what works, and then also say, how do we harness everyone's interest and enthusiasm to keep on looking at this. For me, the appeal of clinical academia is that it makes sense of my clinical practice with this impetus to constantly look at how we improve outcomes. A lot of my research comes from what I see in clinical practice and the gaps that I see. And plenty of our maternity care is underpinned by the evidence that we have acquired over the years and decades, so that the care is better directed. But we're left with outstanding research questions that drive me to say, how can we improve it? So for example, an area that I'm researching at the moment is, what is the best antihypertensive for the woman and the baby in women with pregnancy hypertension? So we see a gap, and the research allows us to really understand more about how we can tackle this problem. And they're very intertwined. It isn't a sort of unidirectional process. For me, it is a circular process of seeing a need, designing the research, delivering it, and then going around and saying, who did that work for? What more do we need to do to understand it? And this is where the bridges between discovery science, researchers, clinical practice, the life sciences sector is so important, because they've all got a part to play in this, with the ultimate aim of improving how we look at both health, but as I say, health in the widest sense. So preventative health, treatments, and also looking at where social care fits with this, because for a lot of the public, it's that there isn't a divide between health and social care. It is part of the same concept. So I'm really interested in how, why should research be an integral part of clinical care? And I think there are several advantages. So we know from the evidence that patients treated in a research active setting have better outcomes, but it's also interesting to unpick why that might be. So some of it might be sort of more obvious. They have exposure to new treatments, but the benefit may also come from having healthcare professionals who are prepared to question what they are doing, and to strive for high quality evidence-based care. One of the challenges in being a clinical researcher is that you have to practice saying, I don't know, and then say, I don't know, so I've got research that is going to address that uncertainty. And perhaps the COVID-19 pandemic has given the public a better understanding of that uncertainty, because that's where we were in March 2020. There was lots that we didn't know, but it was research and science which the patients and public participated in record numbers that gave us the answers that we were looking for, so that the mortality rate has reduced. So for me, patients benefit from being in that research active environment because they are actively participating in understanding the uncertainty and then doing something about it. And in my experience, it's not the patients that are the gatekeepers. Sometimes we should think about how we encourage healthcare professionals to be enablers of that research, such that we continue to find the better treatments. I think I would encourage anyone with an interest in research, but also I think that it should be an integral part of every healthcare professional's toolkit, because for me it's obvious that if you're going to deliver clinical care, then research needs to be involved in that. I don't think there's anyone involved in health or social care that couldn't be a part of that, because of what I've talked about in terms of the constant strive for improvement. We don't need to stand still. We don't have the answers we don't have the complete answers in any sector. So for me, it's about starting early at the undergraduate level and even in schools to say that research is just part of business as usual, and then ensuring that we provide opportunities both for tasters in research or participation as enabling it, offering it to patients, and then for those who want to make a more specialist career, making sure that we look at how we enable people to step sideways. But actually, I still have this passion that research should be business as usual across the NHS and social care. So maybe we've got some opportunities to think about how to see that happening off the back of the COVID-19 pandemic, where that was actually across every single care setting in the last year. I think there are several misconceptions about clinical academic careers. And that may be because of some of the structures at the moment. So some of them are that it's just for doctors. It isn't. We should make academic careers accessible to everyone who plays a part in health and social care. And I would say that the National Institute for Health Research has really led on this in opening up all of its schemes. And there is more work to do to make sure that they are genuinely accessible. So we should dismantle the barriers to the perception that it's just for doctors or a certain socio-demographic group. And we could go further and look at our geographical spread of funding, and also something that the current Chief Scientific Advisor, Chris Whitty, has championed, which is research following patient need. It seems so obvious when you say it, but the research should be happening where the disease burden is highest, so that both the research is done efficiently, but it reaches patients where that is a real problem. And I think that's something that also has a role to play in addressing the health inequalities. And I'd really like to see how we ensure that that momentum is continued to make sure both the research is done with patients where the disease burden is high, and by researchers that are representative both of all the disciplines and in many sort of terms to ensure that diversity and inclusivity. So clinical academic life has uncertainties, and it's probably taken me a little while to realize that those uncertainties can also be seen as opportunities. I have not had a straight line career. My career has had zigzags, and I've tried to reframe those uncertainties in terms of where can I take on new avenues of research or new ways of working that sometimes lead down a dead end, and I have to retrace my steps. but also sometimes lead to exciting new collaborations or new ways of thinking. And I've done that by sometimes taking the uncertainty and looking at it from a different perspective, or working with someone who's provided a different perspective. And this is where the advantages of working with a diverse group come up. Yesterday, I was talking to some of my group, and they'd just been through a sort of profiling, and it turned out that I had a wonderfully diverse research group, which filled me with joy because they see things differently to me, and I enable them to come up with those cognitively diverse ideas so that we reach solutions differently. So sometimes dealing with those uncertainties can be framed in a way that enables people with different perspectives to contribute to it. And for me, that is the excitement of collaboration outside of my immediate bubble, and very much with patients and the public, which has sort of run through all of my pregnancy research. Because again, patients and public see it differently, and we're really understanding that, for example, through patients with multiple long-term conditions, where it's not about my agenda, it's got to be about what's important to them. So I'm seeing uncertainty now more as an opportunity than a threat. There are much bigger benefits to clinical research to the immediate patient. There will be often direct benefits to patients or the public in a setting. But I think there are wider benefits both in for a society in constantly striving to improve particularly quality of life, and to ensure that we are making strides in the health of the nation. I think we've got a really vibrant life sciences industry in the UK, and I think we've seen that in the last year with the COVID-19 pandemic. And I think we have an opportunity to work in a very transparent way with the life sciences sector to say this is something that we care about, both from a public and an academic perspective. But in order to do that, we've got to take the public with us. For example, if we're going to use health data, we've got to understand opinions on how that is used carefully, transparently, sensitively. So I hope that the COVID-19 pandemic has given us opportunities to have those bigger conversations and to listen to all opinions, so that we can continue, I would argue, to punch above our weight from the UK perspective, with that focus on improving health of the nation. I think one of the things that I wish I'd known was around not necessarily having it all planned out, and that opportunities come your way throughout your career, and it's what you do with them that counts. I never imagined that I would be sitting in the role that I am in today, either as a professor of obstetrics or heading into the chief scientific advisor role. And what's got me there? I think I've got this curiosity, and I think if you can shape your own curiosity into what fires you, that's really helpful. And I think that you, in a health research career, you also have to have some perseverance. So I'm now able to sort of say publicly, I've had grant rejections, I've had manuscript rejections, and I'm now looking after my fellows who are in the same position, and I still care about them, but I try and pick myself up. And if I've got something that's important, I persevere, because if I think it matters to patients and public, then I will keep going at it. So I wish I could have told myself to hold out, and hold on to that belief that there will be opportunities coming your way, and to try and find a way of spotting them. I think one of the impacts of my career has been somewhat fortuitous in because I've had the opportunity to see a new diagnostic test go from bench to bedside and into clinical practice. And it's fortuitous because I did a PhD in preeclampsia, and I happened to measure a biomarker called placental growth factor. And 20 years later, the NHS England has rolled it out into clinical practice. And it's reminded me about the importance of so many components of the research pipeline. I say pipeline advisedly because, as I mentioned earlier, I think it should be a circle, because now that we've got it into clinical practice, I go back round again and say, how could we do better? What else do we need? So it's been through a case control study, it's been through a cohort study, a trial, it's gone into implementation. And it's really unusual as a researcher to see one aspect of your research that goes through all of that. It's had input from the industry partners, it's had funding from the National Institute of Health Research and other funders. So it just exemplifies that funnel that takes an idea from first conception, as we say in the pregnancy world, through to delivery. So I'm lucky enough to have had a number of really positive role models, and also some who haven't been quite so positive. So I'm just going to go back to medical school when I was doing obs and gynae, and a consultant called Rafe Robinson was one of my consultants at Addenbrooke's at the Rosie Hospital, and who just got me thinking differently. And it's one of the reasons I'm in this specialty. He talked about a much wider approach to interactions with a woman, a pregnant woman, or in gynecology. And so that sort of wider horizon sparked my interest in lots of ways. And then through my career, I've had people, Professor Andrew Shannon, who's a professor here at King's College London, who I would say have nurtured that interest, and who have seen me through the tougher times that, when there's not so much funding coming in, have enabled me to spread my wings when I'm ready, but with that support. And so I've tried to follow that approach of supporting the fellows that I look after, and the midwives, and all the people in my group, whether it's technicians or whoever, to spread their wings, because it's about our legacy. Our legacy is those who come after us. And if you appoint the brightest and the best who are allowed to fly, it's fantastic from a supervisor's perspective, but that's where the legacy will be in who comes next.